Hi, good evening everyone. So this week we'll be continuing our lecture series on various topics of dermatology, and I think this video will release on 1st of October, and 1st of October is also known as World Urticaria Day. Okay, so for the residents who might get this kind of question in their viva, when is the World Urticaria Day celebrated? It's on 1st October, and I thought what would be a good way to discuss urticaria. That Nothing would be better than discussing the pathomechanism of urticaria. Now, we did touch upon this topic while I was discussing the first generation antihistamines. And the reason I wanted to do this in detail that while I was researching for those antihistamine videos, I came across that the pathomechanism of urticaria superficially looks very simple. Okay, we think that it's mainly because of histamine mediated wheal formation or any kind of mast cell degranulation is going to cause urticaria, and we end up giving a lot of antihistamines, and when the 4 times the dose doesn't work, we shift to an autoimmune urticaria scenario and give immunosuppressives. But it would be a good idea to understand how does urticaria develop, and so that we may know when to suspect an autoimmune basis of urticaria. If a person is not responding to the initial doses of antihistamine, or the response is not at all adequate or significant, it's better to evaluate the patient for autoimmunity as the basis of the wheal formation. And we need to segregate these patients, separately from those who respond very well to antihistamines, uh, against those who will not respond that much, benefit better on antihistamine. And it's important to realize that those patients who do not respond to antihistamines, we should start on immunosuppressives for those patients, because that is the only thing which is going to give them a good improvement in their urticaria. If we have an autoimmune basis of urticaria, then the patient will have much more significant and worse psychosocial impact. And that, as dermatologists, we should realize that, so that we don't keep on pumping higher and higher doses of antihistamines when we do get the idea that it is not responding. Okay, so with that, without any further discussion, we're going to start our weekly discussion. This week, we'll be discussing on the World Urticaria Day, the pathomechanism of urticaria. Now, you would be wondering why I have a plant on the title slide. So, this plant is known as Urtica dioica or dioica, however you want to pronounce it. Okay, Dioica. So the in 19th century, when urticaria was being described by various people, various clinicians, the wheal formation was also seen when the leaves used to touch or braze against the skin. And since the scientific name was Urtica dioica or dioica, they named the disease as urticaria. So that's where the disease gets its name. Okay, so this is Urtica dioica. I think the common name is common nettle plant. Okay, so this is the common name of this plant, and from the scientific name of this plant, we get the word urticaria. Okay, so let's move forward, and we'll be discussing the pathomechanism of urticaria. For understanding the wheel formation, it's important that we should know about the triple response of Lewis, and this is a very good Viva question, especially from first or second semester junior residents. We were always asked about triple response of Lewis. So, on sharp stroking of skin, there is a release of histamine causing initially erythema, then flare, then wheal. Okay, this order is important. Okay, so first erythema, then a flare, and then a wheal. Let me just make it again. So initially you have erythema, from erythema you have a flare, and from flare you have a wheal. This is important. Erythema, flare, wheal. Erythema happens because of capillary dilatation. It takes roughly about 15 seconds to develop. So there is generalized redness of the skin. Okay. After that you have the flare, which is due to arterial dilatation, and that is because of axon reflex. Now this word is important. You have to mention that word while discussing triple responsive Lewis. That the second part of triple responsive Lewis occurs because of axon reflex. and this happens in round about 45 seconds or within a minute. The third part is the wheal formation, which is because of capillary and venule permeability, increased permeability of capillaries and venules, and this takes about 3 to 4 minutes to establish. The first we have just generalized edema, which takes roughly about 15 seconds. Then you have an intense flare, intense erythema, and that is about 45 seconds to 1 minute, and that is because of an axon reflux. Okay, so because axon reflex, if I just go lightly, it is just because of a neuronal mediated vasodilation, arterial dilatation in this case. And then you have the proper wheal, that is the pathognomic skin lesion of urticaria. Okay. So this triple response of Lewis is necessary for understanding, because whenever we are checking for dermographism, we need to separate it from triple response of Lewis. So what I usually do is I stroke the patient on the forearm, on the volar aspect of the forearm, and then wait for at least 5-10 minutes, 15 minutes while I'm taking the history, and then record my observation. The dermographism has to be present at that point of time. If it comes quickly and goes off quickly, then it's possibly because of triple response of Lewis. But if it stays there and if it comes after let's say 5 minutes, 10 minutes, it's more of a dermographism. So that distinction has to be there. Otherwise, we will keep on labeling patients having dermographism or dermographic urticaria while they are just showing the triple response of Lewis. Okay. Let's come to the topic at hand. For urticaria, the definition is wheals which resolve within 24 hours. So this is important. Usually the books mention 2 to 24 hours as the duration of wheal, but wheals have to resolve within 24 hours. That is important. Now the patient might say that the disease is lasting for many days. The disease can last for howsoever many days. Okay, whatsoever many days. But individual wheal should resolve within 24 hours. And if you have any doubt and if the patient is admitted, you can just make a pen mark around the boundary of the wheal and click a photograph and then compare that next day and see if the wheal has changed. If the wheal lasts for more than 24 hours, you should consider diagnosis of or differential at least of urticarial vasculitis, and this disorder shows histopathological features of vasculitis, but there is wheal formation and the wheals will be long lasting more than 24 hours. Now, what do we mean by wheal? This definition is important. It is very routinely asked in the vivas. So, wheals are pruritic, pink or pale swelling of the superficial dermis. This is important. Superficial dermis with or without an erythematous flare around it. Okay, so it is a swelling of superficial dermis which is itchy, pink and pale, and has an erythema around it. In contrast, angioedema is a deeper swelling. Okay, so this is a distinction. It's a deeper swelling, it's painful, it's not itchy. Remember our discussion on pathomechanism of pruritus, that itching is just itching when it crosses a certain threshold will become painful. And those both of these sensations are carried by the nearly the same nerves. Okay, so angioedema is a deeper swelling which is painful. It is less well defined and lasts for about 2 to 3 days, and this is a severe manifestation of swelling. If it occurs with wheals, that means more or less it is histamine mediated, and urticaria with angioedema is majorly because of histamine, and the antihistamine will have a role in their management. On the other hand, if wheals are not there and if we have only angioedema, then it could be because of some kind of C1 esterase inhibitor deficiency, and that is mediated by bradykinin. And this might not respond adequately with antihistamine. It's better to switch to immunosuppressives. The prevalence of urticaria is about 8 to 22%. Some say it can be as high as 1 to 40%, but 8 to 22 is what I think Bologna mentions. Out of this urticaria, chronic urticaria is roughly 2 to 3%. Some books mention 1.8. I think Rooks mentions 1.8. So Bologna is 2.2 to 3%. Point prevalence at one point of time, it is 0.1 to 0.9%. Female to male ratio is about 2:1. That means females are double the amount of females are affected by chronic spontaneous urticaria, but this ratio is very variable for physical urticaria. For example, if you have a pressure urticaria, then most likely the gender which is going outside the home and working might be developing commonly the pressure urticaria, and that is why the ratio is not that static for inducible urticaria, but for spontaneous urticarias, the female to male ratio is 2:1. The incidence of hereditary angioedema is 1 in 20,000 to 1 in 60,000. Okay. So let's go with types. Now, type of urticaria, the most common type distribution or most common classification that we use is chronic and acute. Chronic is when it is more than 6 weeks, and acute when it is less than 6 weeks. Okay. Now we have to realize that the whole urticarial episode should last for more than 6 weeks or less than 6 weeks. Okay. If a patient has one episode of urticaria and it gets resolved within 2 to 3 days, and after 8 weeks they will have another episode, then it's better, and the patient was normal in between, it's better to call it as an acute but episodic urticaria. Okay, instead of calling it as chronic spontaneous urticaria, we should call it as acute episodic urticaria. Now remember, the term that chronic idiopathic urticaria should not be used right now. It's better to use chronic spontaneous urticaria. CIU should be limited to chronic inducible urticaria. Okay. Now these are the two classifications that we routinely use. Another classification is based on the pathomechanism. So type 1, which is also known as autoallergic urticaria, is because of IgE antibodies which are directed against self-antigens. Now these antigens can be either TPO antibodies, the thyroid peroxidase, or it could be thyroglobulin, or it could be dsDNA, or it could be interleukin 24. Okay, let me just write it clearly again. These antigens against which IgE is directed could be thyroid peroxidase, thyroglobulin, interleukin 24, dsDNA. These are some of the antigens. There can be a whole lot, many antigens, but these are some of the self antigens against which IgE is directed, and that leads to type 1 urticaria or autoallergic urticaria. Type 2 is divided into two types, type 2A and type 2B. Type 2A is because of antibody mediated activation of the complement system. Now, activation of the complement system is one of the other pathways through which urticarial wheals can occur. Okay. I will not be going into detail about the complement system. It's a very complicated system. Maybe in some future video, we'll discuss about the complement system and its activation and various clinical scenarios. But remember that the activation of complement system, when it leads to urticaria, that is known as type 2A. Okay. Type 2B, which is one of the most common types of urticaria, is known as autoimmune urticaria, and it is implicated by, it is controlled by the IgG type of antibodies. So IgE type 1, IgG type 2. Out of these, IgG1 and IgG3 are the most commonly implicated, and these IgG antibodies are against the self IgE antibodies. So remember, in the first generation antihistamine video, we discussed about the Fc epsilon receptors. These are the receptors for IgE. If IgE leads to histamine release, it is type 1. And if IgG leads to histamine release, it is type 2. Clear? IgG antibodies can be against the IgE of the patient, or it can be directly against the Fc epsilon R1 receptor. Okay. Just remember that if it is because of IgG, it is type 2B. If it is because of IgE, it is type 1. Now this autoimmune IgG or the autoimmune type of urticaria or type 2B type of urticaria is seen in 25 to 30% of chronic spontaneous urticaria. The clinical implications are that they are more prone to other autoimmune conditions like autoimmune thyroiditis, diabetes mellitus, okay, other autoimmune disorders. They tend to increase in these kind of patients. To diagnose that, a good test are Basophil Activation Test, autologous serum skin test, and anti-IgE or anti-Fc epsilon R1 antibodies. You directly check for these antibodies. The method that you use is Western blot. Western blot to look at these antibodies. And in roughly about 8% of all patients, all of these three could be positive. You just require one positive test. The best test is, I think, Western blot, but BAT and BAT can easily be used. ASST has its own complications, has its own drawbacks. Okay, so it's better to actually find those antibodies which are implicated, and in 8% of patients, all three of them could be positive. The pathomechanism of urticaria goes through multiple steps. First, it starts with the mast cell, and mast cell is the most important cell in the pathomechanism. For example, in psoriasis, we had the lymphocytes and neutrophils, while in urticaria, it is the mast cell which is the center point of attention. Then you have a degranulating stimuli, that means any stimuli which eventually leads to degranulation from the mast cells. Okay. Now, a mast cell has a lot of vesicles inside it, and all those vesicles have histamine. So, when there is degranulation, and the term that we use is known as explosive degranulation. So, there is explosive or intense degranulation, and any mediator which leads to this kind of degranulation and intense release of histamine will cause urticarial wheals. The pro-inflammatory mediators are those mediators which are stored inside the vesicles in the mast cells. The most important and the most common is histamine, but there are other mediators also. We'll discuss them eventually. When these mediators are released because of a degranulating stimuli, they act on the blood vessel to increase the permeability. Other things also happen, but we will discuss that in detail. So there's increase in permeability leading to localized swelling and wheal formation. And the last step is blood. Blood means what happens after the wheal initiation process has started. So you have autoantibodies which can lead to persistence of urticaria. You have leukocytes, majorly basophils and eosinophils which are implicated, and other mediators which are not so common as histamine or any other mediators. But these other mediators may lead to persistence of urticarial wheals. Okay. So let's discuss the mast cells. So mast cells are the primary effector cell for urticaria. They can have phenotypic variation. That means can have a variable concentration in the skin, gut mucosa, bronchial mucosa. Okay, so this concentration can vary. Okay, and in fact the presence, for example, by phenotypic variation we mean that the presence of histamine in the vesicles or presence of other mediators like tryptase, substance B, other mediators can also vary. For example, cells in the skin or cells in the lesional skin, the urticarial skin of patients, the mast cells were found to have more of these mediators or easily releasable mediators, or increased concentration and number of mast cells were found in the lesional skin. So they can vary depending if the skin is affected or not, and they can also vary by the position in the body. Okay. They may also have variable response to stimuli. For example, in patients who are more prone to develop urticarial wheals, their mast cells may be genetically predetermined to be easily responsive to degranulating stimuli. Okay, so people who do not develop urticaria they might not have this kind of labile mast cells which can easily release histamine. So that's what I'm trying to say, that they can have variation in the presence and absence and working, and they can also have variation in response to stimuli. Now, mast cells are very important for innate response. Histamine is very important for activation of eosinophils, for activation of basophils, activation of mast cells, and they are responsible to increase the innate immunity action against various pathogens, and majorly the parasites also. So a lot of you see what is happening. The vessel permeability is increasing, and what happens when vessel permeability increase? There's increased migration of inflammatory cells from the from the central pool to the peripheral pool at the level of skin. And when a lot of inflammatory cells reach the skin, there is inflammatory damage and inflammation, and inflammation is required to take care of an exogenous, any external pathogen. So that is how the mast cells are become a very key cell in the innate immunity response. The receptors that we'll talk about in detail is Fc epsilon R1 alpha receptors, which are denoted by this green solid arrows, and these receptors are the major receptor which mediate urticaria and mast cell activation. Discussing about the degranulating stimuli, we will nearly all the stimuli or the major stimuli act through the Fc epsilon R1 receptor, and IgE is the antibody which majorly attaches itself to the Fc epsilon receptor here. So there are two types of receptors. You have R1 and R2. And R1 is the one which is present on mast cell, and it has high affinity for IgE. Okay, so R1 has high affinity for IgE. Okay, when Fc epsilon R1 is activated by an IgE antibody, which itself has been activated by any other antigen in the body, this leads to histamine release. Clear? There are other mediators like opioids. We have discussed about opioids causing itching. Okay, C5a, which is known as anaphylatoxin, stem cell factor, substance P. Now these other mediators, which do not require IgE for the activation of mast cells, they act independent of Fc epsilon receptor 1. They have their individual receptors. Clear? So IgE is going to act through Fc epsilon R1. You can easily remember epsilon here, which means E. So IgE. So Fc epsilon receptor is the major receptor for IgE attachment. Okay. Now cross-linking of two Fc receptors. Initially what happens is these Fc receptors are separate, and when IgE attaches itself to it, it leads to cross-linking. These two they come together and they cross-link with each other, and this leads to the activation of receptors, leading to secondary messengers, and eventually it leads to explosive degranulation of histamine. Clear? Let's move forward. So this slide would be just a recap of what we had discussed. Of what we had discussed in the video on antihistamines first generation. So I'll just go very quickly through this slide. If you want to look at it in detail, it's there in the video. Okay. So this is a mast cell, and it has lot of vesicles which include histamine, which contain histamine. So, and these green arrows are the Fc epsilon R1 receptors. So first what happens is an antigen will attach itself to IgE, and IgE will get activated. Okay. Now this activated IgE will attach itself to the Fc epsilon R1 alpha receptor, and this receptor will then get activated. This is known, IgE is the activation of IgE is the type 1 endotype of urticaria, which is also known as autoallergic. We have discussed that in the, I think, third slide of this video. The second method is that you can have an IgG antibody against the patient's IgE antibody. So what happens is, in the absence of antigen, there is no antigen, but in the absence of antigen, the autoreactive IgG will attach itself to the IgE antibody, and this complex will attach itself to the Fc epsilon receptor. So this is known as the type 2B or autoimmune type of urticaria. The third step is that you have IgG, which independently activates Fc epsilon R1 alpha receptor. It does not require any attachment to IgE, and this third type is also known as 2B or the autoimmune type. So there is type 1, which is IgE mediated. There is type 2B, which is IgG mediated or autoimmune urticaria, and IgG mediated urticaria can be of two types. Either the IgG will attach itself to IgE and then activate, or IgG can activate independent of IgE. Clear? So that is how activation of the Fc epsilon R1 receptor takes place. This leads to an explosive or massive degranulation of histamine, leading to wheal formation. So this is a good diagram that I saw in Bologna on page 305 of the 4th edition. You can go and read that chapter. It's a very good chapter. And it just shows that you have Fc epsilon receptor activation. So this circle, this half circle, this semicircle is actually showing Fc epsilon receptor. So this is allergen and IgE mediated activation, or the type 1. Okay. This is you can also activate the Fc epsilon receptor by the attachment of antibodies directed against those receptors. So if IgE antibody, sorry, my mistake, if IgG antibody is there in the patient which acts against the Fc epsilon receptor, then this will activate, which is the 2B. This is actually the third step in the last slide. Okay. Or if there is IgG antibody directed against the IgE antibody, it can activate the Fc epsilon receptor. This is also 2B. This was the second step in the last video. Okay. So here we have discussed about the Fc epsilon receptor mediated degranulation of mast cell. Other mediators like substance P, stem cell factors, C5a or anaphylatoxin, codeine, they have their individual receptors separate from Fc epsilon, but they do lead to activation of mast cells, leading to explosive degranulation. So the degranulation has taken place. Okay, we have mast cell full of histamine. We have the stimulus which leads to the degranulation of histamine from outside from the mast cell to outside of the mast cell. Now, other mediators. So, histamine, I've already told you, it's the most common and the most important mediators. Preformed means they're already formed, they're already active, they're just stored, ready for action. Okay. So, we have the most common and the most important one is histamine. Other mediators include TNF alpha. Now, TNF alpha is constitutively activated. What do we mean by that? By constitutively activation, we mean that the mast cells are keep an active TNF alpha ready for action, ready for deployment. Okay, so this keeps on getting secreted. It increases a lot in the presence of any degranulating stimuli. Histamine is not the only stimulus, which only a mediator that gets released upon activation. When mast cells are activated, they are going to release a lot of other mediators also. Histamine is just the most important and the most common one. The other mediators are also going to lead to inflammatory process. Okay, so other mediators include interleukin 3, 4, 6, 8, 13, granulocyte, monocyte, colony stimulating factor. Okay, after histamine and inflammatory mediators, you have eicosanoids. Eicosanoids include prostaglandins and leukotrienes, and these are synthesized from the arachidonic acid from cell membrane. So you have a cell, and if you take a piece of membrane and enlarge it, you have the membrane. And inside the membrane, you have fatty acids, and one of them is known as arachidonic acid. And on the from the metabolism of arachidonic acid, you get prostaglandins and you get leukotrienes. And both of these leukotrienes and prostaglandin can lead to urticarial wheal formation. So remember this when we'll be discussing about prostaglandins. It has been found that PGE2, remember your different types of prostaglandins, PGD2, and you have also have C2 also. Remember that PGE2 has found to be inhibitory for the formation of urticarial wheals. So remember, in the human body, if any process is started, the process to stop the initial process also starts. There's a negative feedback. So if we start a cascade of events in the human body, the process to control that cascade of events also gets started. And that is how brakes are applied to the inflammatory process. And PGE2 is one of those brakes. It's inhibitory. It stops that inflammatory process. So this diagram is just showing that arachidonic acid from the membrane phospholipids under the action of phospholipase A2 gets released in the cytoplasm, and this is a very long process. This diagram has just shortened it out to make it easier to understand. If arachidonic acid undergoes processing by lipooxygenasis, it forms leukotrienes. If it undergoes cyclooxygenasis mediated manipulation, it leads to formation of prostaglandins, prostacyclins, and thromboxane. All these three are known as prostanoids, and these are very important mediator of histamine, mediator of itch and wheals. So what happens? Let's say you take NSAIDs or PCM, paracetamol or NSAIDs. They act as COX inhibitors. So when this enzyme is inhibited, a lot of arachidonic acid will then shift towards lipooxygenasis, and there will be increase in leukotriene. This is one of the mechanisms through which NSAIDs cause urticaria. They block the conversion of arachidonic acid to prostaglandin, and as a result, a lot of arachidonic acid is present, and this shifts the gear towards leukotrienes, and leukotrienes can itself act independently as a mediator of urticarial formation. So this slide is just to recapitulate. It's from Bologna, page 305, that you have a lot of mediators. Histamine is the most common one, important one. You can have heparin, tryptase. Now tryptase can itself activate other mast cells. So it causes a positive loop. So mast cell will release tryptase. Tryptase can activate mast cells. Tryptase can also activate neurokinin receptors. Remember our video on Pathomechanism pruritus. Tryptase can also activate neurokinin receptors, and activation of neurokinin receptors can also lead to tryptase, again a positive loop, or additionally to that, neurokinin activation can lead to itching. So remember, histamine is not the only mediator causing itching and wheal formation. Okay, there are other mediators involved. We also have the inflammatory mediators, the inflammatory cytokines. We have prostaglandins, leukotriene, platelet activating factors. The difference is that these three, the heparin, histamine, and tryptase, are preformed. That means they are already formed, ready for action. And these prostaglandin, leukotriene, and platelet activating factors are newly formed mediators. That means upon getting stimulus of degranulation, the mast cell will start to synthesize them. Histamine is already created, it's already stored. These will be newly formed. They will be formed when the stimulus is received. So the mast cell has received the stimulus, it has degranulated and released histamine and other mediators. Now they will act on blood vessels. So these mediators, when they act on post-capillary venules, it leads to vasodilation. After vasodilation, remember that if your blood vessel wall is lined by endothelial cells, and venules, when they're going to expand, there will be gaps in between the endothelial cell. And what happens is these gaps are going to increase the permeability of blood vessel. Okay, so increased permeability to large plasma proteins, and this plasma protein are going to leak out of the blood vessel just beneath the skin, causing the swelling. And clinically, this swelling can either become a wheal, or it can become angioedema, or it can become both. So that's how swelling happens after the release of these mediators. Additionally, mediators like histamine, interleukin A, TNF alpha, they're going to upregulate the adhesion molecules on the blood vessel wall. And upregulation of adhesion molecules will lead to increased attachment of inflammatory cells, and when these cells are attached to the endothelial cell layer, they're going to increase their migration towards the skin, leading to persistence or increase in the inflammatory activity or inflammation. So this is so first point is how histamine and other mediators increase the vessel permeability, while the second point is how they increase the migration of inflammatory cells, thereby further increasing the inflammation. So we have reached the point at the process where the wheel has been formed. Now what is going to happen in the blood? Other parameters, other things are also changing. Okay, so one of the most important autoantibodies, and we are discussing now, we are going towards a bit in autoimmune urticaria now. The most important autoantibody is functional IgG antibody to the alpha subunit of FcR1 receptor. Okay, remember endotypes: type 1, type 2b. Type 1 is IgE mediated, type 2b is IgG mediated. This is type 2b, or the autoimmune. It is the most common form of autoimmune urticaria. Okay, now what happens is that you have Fc epsilon receptor, and then you have two domains. Okay, one domain is alpha 2, other domain is alpha 1. The IgE antibody attaches itself to the alpha 2 domain. So this is IgE. Okay. The IgG antibody, if it attaches itself to the alpha 2 domain, it will compete with IgE. If IgG antibody attaches itself to alpha 1 domain, there is no competition with IgE. So just to say that Fc epsilon receptor has two domains, alpha 1, alpha 2. Alpha 1 IgG can attach in spite of IgE. There is no competition. In alpha 2, it competes with IgE for attachment. So it is found in roughly about 20 to 30 or 20 to 50% of cases of chronic spontaneous urticaria. And in 10% of the cases, you can also have antibody directly to the Fc portion of IgE. Okay, so IgE alone causes type 1 autoallergic urticaria, while and IgG antibodies to IgE will cause type 2B. Okay, now these antibodies, when they attach to the mast cell, they can also activate the complement system. Remember, the major action is histamine release. Okay, so majorly they are going to lead to histamine and other mediator release, but they can also activate the complement system. And from the cascade of complement system, you have C5a, which is also known as anaphylatoxin, and this will lead to increased degranulation of other mast cells. Okay, now why do we want to study about autoantibodies? The level of these autoantibodies can correlate with disease activity. So let's say you find out what all autoantibodies are there. And if you see that you have a lot of autoantibodies against IgE, then it's a good idea to start immunosuppressive agents, or in fact monoclonal antibodies, to take care of those excessively formed autoantibodies. And when you have if there's a decrease in the number of autoantibodies, your patient would be free from urticaria. Okay, as long as these autoantibodies are not there in the system. The other antibodies that we'll discuss is anti-thyroid antibodies. These are found in about 10 to 35% of the patients. So let's say you have a patient who's not responding to 4 times the dose of antihistamines, and you don't know what is happening. You don't want to increase antihistamine, you don't want to add another class of antihistamine. It's better to search for auto antibodies. Okay, so you will search for IgE, IgG, also search for thyroid peroxidase antibodies. Antibodies against TPO can be both IgE or IgG. If it is IgE, it's type 1. If it is IgG, it's type 2B. Antibodies against only the thyroid molecules are seen in 10 to 25%. Some clinicians consider that as epiphenomena. So what do we mean by epiphenomena? Epiphenomena means just a correl correlation. Not a correlation per se. You could say bystander. That's a better word. Bystander. That means they may not have that much implication on the development of urticaria, but they are just present in the system. So if a patient has positive TPO, some patient might consider that as just a presence there, not particularly an implicated antibody in urticaria. Now, IgE antibodies against thyroid peroxidase can cleave C4. This is the pathomechanism of how antibodies against TPO will lead to urticaria. So you have C4, and when it gets cleaved, it forms C4a, and this C4a can further lead to complement activation. Okay, so that is how anti-TPO antibodies leads to urticaria. They cleave C4, form C4a, and lead to further complement activation. Now, if your patient has antibodies to thyroid molecules, they may respond to thyroxine or thyroid supplementation. So just search for T3, T4, TSH levels, anti-TPO antibodies, and if there is a not clinical per se, if there's a laboratory evidence of thyroid disorder, treating the thyroid disorder might help in good resolution of urticaria. I could not find how many patients do benefit from addition of thyroxine or thyroid hormone in their regimen if the urticaria is not responding. If in the future I do find it, I'll share the article with everyone. But there have been instances when supplementation of thyroid hormone has led to better control of urticaria. So we have discussed mast cells in details. Okay, mast cell is the primary effector cell in urticaria. Now we'll discuss in brief other cells, majorly basophils and eosinophils. So basophils, they are less responsive to anti-IgE antibodies. They are also less in number as compared to mast cells. Okay, so mast cell is the major cell which gets activated because of anti-IgE antibodies. Basophils also get activated by anti-IgE antibodies, but the intensity of activation is very less as compared to mast cells. The activity of basophils in response to any allergen is measured by two tests: Basophil Histamine Release Assay and Basophil Activation Test. We'll discuss them very briefly in the next slide. Now, basophils can have a role in persistence of disease. That means, remember that you are treating a patient of urticaria with antihistamine, and the moment you stop antihistamine, the patient has a relapse, or it is not the patient is not responding well to antihistamine. So, basophils can have a role in persistence of disease or a sustained inflammatory response. So, we need to take a look on basophils also. Now, basophils also release interleukin 31, and this is a very important interleukin for chronicity. That means chronic nature of any itch disorder. Okay, so it leads to pruritus, and there's a role in chronic disease. And this interleukin 31 is implicated mainly in atopic dermatitis. Now remember, if your patient has basopenia, and this is a bit difficult to understand because basophils are roughly 0 to 1% in differential leukocyte count, so you might not be able to understand if basopenia is there. But if basopenia is present, it means that the disease activity is high. Why? Because basopenia means decrease in number of basophils. And why the basophils are decreased? Because a large portion of basophils are at the skin, not in the blood. So blood will show basopenia. Okay, so if they are present as skin, that means inflammatory damage is going on at the level of skin. So basopenia leads to high disease activity. Now CD63 is very important. CD63 expression is a marker of activated basophils. So if you have a basophil, the CD63 will be inside the cytoplasm, and when it gets activated by any stimulus, the CD63 will migrate on the cell surface, and expression of CD63 means that the basophil has been activated and it will release the mediators. So let's discuss very briefly about basophil activation test. Now what happens in basophil activation test is you have a basophil and then you activate it by exposing it to certain allergens. These are patients basophils. Okay, these are patients basophils, and patient basophils are activated by exposing them to allergens. Let's say you have a patient of peanut allergy and you want to do BAT. So you expose the patient's basophil to peanut allergens. After after activating the the basophils, there will be increased expression of CD63. And when CD63 is increased, that means the basophil is activated. And we measure the number of basophils that show CD63, and that is known as basophil activation test. Okay, so you have a basophil, you take it from the patient, you expose to certain allergens which you are testing. If the basophils express CD63, that means they are activated, and we measure the number of basophils which show CD63 to have a quantitative analysis of allergy. So basophil activation test assesses the IgE cross-linking, and the proportion of basophils that are activated will tell our severity. So more number of basophils which are activated and show CD63, the more severe the disease. And sensitivity of this test, sensitivity of the activation of basophil tells the lowest dose of allergen. If the basophils are activated with the minimal amount of dose of allergen, that means the patient is very sensitive. Even a small dose of allergen will lead to urticaria. If a large dose is required or a large threshold of activation of basophils are there, that means a large dose would be required. Treatment with omalizumab decreases the number of basophils which are activated, so there will be a decrease in BAT. So you can use this BAT test as a therapeutic modality, sorry, not therapeutic, as a measure of therapeutic response. Okay, so pre and post levels can tell you a lot about the response of activation of basophils. Now this is a graph, a general graph of basophil activation test. You just keep on increasing the concentration of allergen, and after a certain point you will see that the number of activated basophils keep on increasing, and then it reach a plateau, and this is the maximal reactivity, and that is how you read a basophil activation test. Now, Basophil Histamine Release Assay. Now, why these tests are important? BAT and BHRA. They will tell you about the sensitivity of basophils in patients who are not responding to urticaria, number one. Number two, in the future, when you will read about articles regarding the efficacy of treatment of urticaria, you will come across these terms as BHRA, BAT. And so, we need to know what do we mean when we discuss that BHRA is decreased after treatment or BAT sensitivity decreases after treatment. So, we should know about these tests. So what happens is you have healthy donor basophils. So in the BAT you had patient's basophil. This time you have healthy normal basophil, and then you incubate it with patient's serum. So the serum is from patient and the basophil is from a healthy donor. And after incubation, you destroy the basophils by perchloric acid and you look at the amount of histamine which is released. Okay, so initially, let's say normally without activation you had this much histamine. After activation you have this much histamine. If this delta, this difference is more than 16.5%, that means you have BHRA positive. Okay, what do we mean by BHRA positive? That means patient's serum has autoantibodies to the specific allergen that we are testing for. Okay, so if BHRA shows more than 16.5 release of histamine, it means BHRA is positive. And what do you mean by BHRA positive? That means the patient will respond very well to cyclosporin and omalizumab, but the response will not be adequate with antihistamine. So in the future, when BHRA tests are so easily done that you can do it on an OPD basis, you will instantly come to know that this patient is not going to respond to antihistamine. It's better to switch to omalizumab, cyclosporin, or other immunosuppressive drugs. Coming to eosinophils, these are the second most important, or the second cell that we are discussing after mast cells, apart from mast cells. So eosinophils secrete a lot of chemical mediators like leukotrienes majorly and the major basic protein. All of these mediators will release histamine and other mediators from basophils, and this will lead to persistence of wheals. So remember, mast cell will lead to initiation of wheal. So this will lead to initiation. Basophil and eosinophil will lead to persistence. Mast cell also will lead to persistence, but initiation is mainly because of mast cell, the primary effector cell of urticaria. If there is eosinopenia, that means disease is much more severe. Similar logic as far as what we gave for basopenia. Eosinophil have receptors which are the Fc epsilon R2 receptor. Remember, in mast cells we have R1 receptor. In basophil we have R2, and R2 is also known as low affinity receptor for IgE. So in mast cells we have high affinity, in eosinophil we have low affinity. So these receptors are also present in eosinophils, and when these get activated, this will lead to degranulation like we see in mast cells. So the important mediators are major basic proteins and eosinophilic peroxidase, and this will lead to mast cell release of mediators, and there will be continuous release of mediators from the mast cells because of eosinophil, leading to persistence of disease. Eosinophil also has tissue factor that will activate the complement system, which will release thrombin, which will further lead to mast cell degranulation. So that is how there will be persistence of disease when eosinophils and basophils are also activated. And when there is activation of other cells apart from mast cells, that means other mediators are involved, other autoantibodies are involved, and it's better to switch to immunosuppressive drugs. Clear? So eosinophils can enhance chronic urticaria in three ways. You can have stem cell factor, which can lead to recruitment and maturation of mast cells. You can have proteins like the major basic protein or eosinophilic peroxidase, which provokes mast cell degranulation. Or you can have activated eosinophil, which will lead to tissue factor, which will activate complement system by thrombin. And complement system can independently activate mast cell. This is how eosinophils can lead to persistence of urticaria. They can also prime the skin for further whealing. That means the recurrence of wheals increases in the presence of eosinophil activation. So we have discussed how mast cell leads to urticaria. We have discussed how basophils lead to urticaria. What is the Basophil Histamine Release Assay? What is the Basophil Activation Test? We have discussed how eosinophil leads to chronicity of urticaria. Now this slide just shows other mediators that might be involved. We have discussed in detail about not use per se, the implication of substance P in causing pruritus and urticaria. So we have discussed that in previous videos, the pathomechanism of pruritus. Just go back and look at that video. Every funda of pruritus would be clear. So substance P, this mast related G protein coupled receptor X2 is one of the newer coming mediators. It's an important mediator. So we might be hearing a lot about this in the future. C5a receptor CD88, it has been found in skin and synovial mast cell, and it is responsible for mast cell degranulation, which is one of the factors that why a patient who can have severest forms of urticaria might not have bronchial asthma or respiratory breathing during the process, because they might be mediated by C5a, or additionally or also mediated by C5a, which are majorly found on skin and synovial mast cells. Heat shock protein, these are all newer mediators which have been implicated. Further studies are required, but if you want to just mention them, you can mention them in viva, that other mediators apart from preformed and newly formed mediators include substance P, mast-related G protein coupled receptor X2, C5a, and heat shock protein, but further studies are required. So we have discussed about the players in the pathomechanism of urticaria. We have discussed about the cells. We have discussed about the mediators. Now the mechanism of how urticaria or angioedema happens, there are three mechanisms majorly. You have the first mechanism is known as mast cell dependent. That means if you require mast cell for the development of wheal. So it can be idiopathic. That means the cause is not ascertained. It can be immunologic by the presence of autoimmune antibodies against the receptor or IgE. You can have the IgE dependent or the allergic one, which is the type 1. This is the type 2b. Okay. You can have immune complex mediated or vasculitic, mostly implicated in urticarial vasculitis, or the kinine or complement activation, which is usually seen in hereditary angioedema. So these are the immunologic methods of mast cell dependent wheal formation. The non-immunologic method of mast cell mediated wheal formation is when you have direct mast cell releasing agents like opioids. You have vasoactive stimuli like nettle stings, remember the plant on the first slide, or NSAID induced urticaria, or ACE inhibitor induced urticaria or angioedema. So these are non-immunological but mast cell dependent method of urticaria. So in mast cell dependent, there is IgE activation against the Fc epsilon receptor. That's one of the one of the immunological methods of urticaria. And this is implicated in episodic urticaria, contact urticaria, physical urticaria. Remember that IgE is mediated majorly in the acute forms of urticaria, not the chronic forms. If urticaria is prolonged and it's going into chronic urticaria, most likely it is because of autoimmune or autoantibodies. It is not because of IgE mediated activation of Fc epsilon receptor. It is because of IgG or other antibodies against different kind of self antigen causing chronicity of urticaria. So in cases of acute urticaria, IgE is implicated majorly, while in case of chronic urticaria, IgG is mediated majorly. Okay, there could be a new antigen mediated activation of IgE, which we know as again type 1. In cold urticaria, it has been found in few studies that platelet clumping or release of platelet activating factor at lower temperatures can lead to activation of mast cell. Remember, we are still discussing mast cell dependent method of urticaria or mechanism of urticaria. So in cold urticaria, some of the studies show that platelet clumps, the clumped platelet can itself activate mast cell, or clumped platelets might release platelet activating factor, and PAF can further degranulate mast cell causing urticaria. This is one of the mechanism of cold urticaria. I can also mention that in solar urticaria, under the presence of UV light or other spectrum of light, the antigens present in skin or the circulating blood can change into a new antigen or neoantigen, which will further activate IgE and lead to acute solar urticaria or acute urticaria. Now, in spontaneous urticaria, we have discussed that there is increased vascular permeability causing plasma leakage, and when the plasma leaks through the blood vessel walls, it leads to more exposure to autoantibodies, and you have chronicity urticaria. It keeps on getting exposed to new antigen, new antibodies, and the urticaria becomes prolonged. In 70% of the patient of chronic spontaneous urticaria, no antibodies are found in tests. That is why I don't get tests done unless the patient is not responding. If the patient doesn't respond, I go forward and look at the other autoantibodies. Few markers like D-dimer or prothrombin fragment 1 and 2 are now mentioned in various articles, and increased levels of these factors means the disease is severe. The severity of disease there, and decrease after treatment shows a good response in urticaria. Additionally, when mast cells are activated, they will also lead to diversion of arachidonic acid metabolism from prostaglandin to leukotriene formation. So, for example, when you use, let's say, NSAIDs, I told you when we were discussing prostaglandin that NSAIDs block the cyclooxygenase enzyme. There will be more of arachidonic acid which will go to the lipooxygenase pathway and form leukotrienes. And leukotrienes are itself newly formed mediators of urticaria. So these are the various methods: IgE activation, presence of a new antigen, platelet clumping, UV mediated activation of antigen, spontaneous urticaria leading to plasma leakage, diversion of arachidonic acid from prostaglandin to leukotriene. All of these methods will lead to mast cell degranulation causing urticaria. That's why they're known as mast cell dependent mechanism of urticaria. Now, it has been found that the mast cell numbers are increased in skin. The mast cell in skin have higher concentration of tryptase, they are easily activated, and also the presence of substance P receptors are increased on those mast cells. Remember, in the initial part of this video we were discussing that each of these mediators have different receptors on the mast cell, and the mast cells are phenotypically variable, and they are much more responsive to histamine releasing chemicals. But all of them is somewhat controversial, not controversial, you could say equivocal. Yeah. So further studies are required to pinpoint that if mast cell in patients suffering from urticaria are actually different from normal people who do not have urticaria. Not normal people, other people who will not have urticaria. So we have discussed about mast cell dependent urticaria. Now very short discussion about mast cell independent urticaria. In mast cell independent, the prostaglandins are implicated. Remember that in mast cell dependent, you have shifting of prostaglandin synthesis to leukotriene synthesis. Okay, but in mast cell independent one, the prostaglandins are implicated. So NSAIDs can be used. Okay, so in mast cell dependent, you should not use NSAIDs because more leukotrienes will be formed, more urticaria will be there. But in mast cell independent, where prostaglandins are implicated, you give NSAID so that you block the synthesis of prostaglandin and urticaria doesn't happen. Other method to cause mast cell independent urticaria is in autoinflammatory syndromes. One that Bologna mentioned is cryopyrin associated periodic syndrome, also known as CAPS. But in autoinflammatory syndrome, you will have other symptoms like fever, malaise, and general symptoms of increased autoimmunity. So in autoinflammatory syndrome, you have a very important organelle known as inflammasome. Very interesting organelle. Maybe sometime if it comes to that, we'll discuss the action of inflammasome in autoinflammatory syndrome. Very interesting organelle. Now, autoinflammatory syndromes they respond well to anakinra, which is the anti-IL-1 antibody, monoclonal antibody. Rilonacept, which is a fusion protein of the IL-1 receptor, it acts as an interleukin-1 trap. That means it traps see, let me just explain very quickly. You have the interleukin-1 receptor, and in this, the interleukin-1 will attach. Okay, what rilonacept does is it looks exactly like the interleukin-1 receptor. So when interleukin-1, instead of going to its receptor, will attach itself to rilonacept and will not be available in the circulation, and IL-1 is removed. That's how rilonacept acts. Okay. Canakinumab is anti-IL-1 beta monoclonal antibody. Okay, and the chronic IgE activation of Epsilon receptor, which is implicated in episodic contact urticaria, physical urticaria, we've already mentioned that. So, mast cell independent mechanism of urticaria seen when prostaglandins are implicated or when we have autoinflammatory syndrome, mainly CAPS. Okay, so we have discussed in exhaustive detail about how urticarial wheals are developed, the role of mast cells, the role of basophils, the role of eosinophils, basophil histamine release assay, basophil activation test. Uh, if the inflammation is very severe and it affects the deeper layers of skin, it leads to angioedema. So very quickly we'll discuss about the mechanism of angioedema. And in angioedema, if it is not because of histamine, if it does not present with wheals, it means most likely it is mediated by bradykinin, and bradykinin mediated angioedema is because of C1 esterase inhibitor deficiency. Okay, so you have C1, a very important part of complement system. The C1 esterase will activate, this will become C1A. So C1 esterase will activate C1A. C1 esterase inhibitor will inhibit the esterase, thereby decreasing C1A. And when this is deficient, this is low, that means C1A will be increased. Okay, so when C1 esterase inhibitor is low, there will be no one to stop esterase. Esterase will keep on acting, and esterase will convert C1 to C1A, and then C1A will increase, leading to complement system activation. And when complement system is activated, you have intense inflammation, and this is the pathomechanism of C1 esterase inhibitor deficiency causing urticaria or angioedema, sorry, causing angioedema. So you have two types of angioedema. You have hereditary angioedema, sorry, three types. You have hereditary angioedema, you have acquired angioedema, and then you have ACE inhibitor induced angioedema. Okay, in hereditary angioedema, you have three types: type 1, 2, and 3. Type 1 has reduced level of C1 esterase inhibitor. Okay, so if C1 esterase inhibitor is low in concentration or the quantity is low, it is type 1. So that is why it is known as quantitative hereditary angioedema. In type 2, the quantity is okay, the number is okay, but they're not able to function fully. They're not able to function to their utmost level of functioning. So the function is reduced, the quality is bad. So it is qualitative hereditary angioedema. And in type 3, the C1 esterase inhibitor is normal. It's normally working. It's normally in right concentrations, but there is an activating mutation of factor 12. So if we discuss, or if you look at complement system in detail, you will find that factor 12 is one of the starting mediators of complement, and when it gets constitutively activated because of a mutation, it will keep on activating complement system independent of C1 esterase. And that is why in type 3 you have the normal level, the normal function of C1 esterase, but you still have angioedema because of constitutively activating factor 12, leading to bradykinin formation. And as we have already told, that angioedema without wheals, angioedema minus wheal, is because of bradykinin. In acquired angioedema, you have C1q activation. Now C1q, when it gets activated, it will lead to complement system activation, and constitutively it will lead to C1 consumption. So when complement system is activated, it leads to inflammatory process and angioedema. And C1q activation or the acquired angioedema is seen in cases like B cell lymphoproliferative disorder or plasma cell dyscrasias or autoimmune connective tissue diseases. So in the presence of these diseases, you have chronic activation of C1q leading to acquired angioedemas in these cases. The third type of angioedema is ACE inhibitor angioedema. In ACE inhibitor, you have endogenous kinase 2 inhibition. So kinase 2 inhibition is responsible for decreasing bradykinin. So you have bradykinin, and kinase is going to destroy the bradykinin. It will destroy bradykinin. Okay, but because of presence of ACE inhibitor, ACE is angiotensin converting enzyme inhibitor. So when ACE is being inhibited, the kinase also gets inhibited, and kinase will not work. There will be increase in bradykinin, and this increased bradykinin will cause angioedema. Okay, and in ACE inhibitor angioedema, mostly orofacial involvement is seen commonly, and it can be life threatening. It can lead to collapse of throat, it can lead to congestion, blockage of throat, patient might not breathe. There could be intense inflammatory damage leading to hypovolemic shock or inflammatory shock, and that can be intensely life threatening. So it becomes very important. So this flowchart I will not discuss in detail. It's present on page 313 of Bologna. It's how to approach a patient of urticarial wheals. If you have recurrent swelling and there's angioedema only but without wheals, we'll discuss them in detail in the next slide. If they're wheals plus minus angioedema, you just find out how long do they last. If it lasts less than 1 hour, more chances of physical urticaria is more likely. If it lasts for less than 2 hours and it is present in a localized area where something came into contact with skin, then contact urticaria is more likely. If it lasts from 1 to 24 hours, then it is most likely acute episodic urticaria. So you give if you give antihistamines, okay, you label it as spontaneous urticaria and you give antihistamines. And if it lasts more than 1 day, you do skin biopsy to look at vasculitic changes and you manage it as vasculitis. So if you find wheals which are lasting more than 24 hours, you get a biopsy done, you look at feature of leukocytoplastic vasculitis, and if that is present, treat it as urtical vasculitis like any other vasculitis. The treatment is like any other vasculitis. Now this flowchart is again at page 315 of Bologna. You have angioedema without wheals. So if there's angioedema with wheals, you manage as the previous flowchart. If there's without wheals, you look at the C4 levels. So C4 levels. So when there is an intense complement activation, C4 gets depleted. It gets used up. So if the level of C4 is less, that means you have a hereditary type of angioedema. That means a constitutively acting. Nothing has acquired. It is because of genetic mutations that you are having angioedema. So C4 will remain to the lower side. So you have hereditary type 1, in which the protein levels are less, and that is why the function is less. In type 2, the levels are normal but the function is decreased. That is why this is quantitative and this is qualitative. And in type 3, we know that it has nothing to do with C1 esterase inhibitor deficiency. It's because of a constitutively functionally active factor 12. Okay, if it is acquired, then acquired, you just look, there are normal levels of C1 inhibitor, but there is decreased function of C1 and the C1q levels are decreased. So remember in the slide for angioedema, acquired angioedema, we discussed that there is C1 depletion, C1q inhibition. And you can further divide into type 1 and type 2 depending on C1 esterase antibodies against the C1 inhibitor. So we might not go into details. These are much more of an academic interest. But if you want to delineate angioedema into hereditary or acquired or ACE inhibitor induced or drug induced angioedema, it's a good thought or a good idea to get C4 levels done to find out, and that is in patients who don't develop wheals but develop just angioedema. Okay, phew. So I think this is the longest video yet that I have made. It's difficult to talk for more than an hour continuously, but these are some reading recommendations. If you want to learn about urticaria and angioedema on a very, very basic level, you read Bologna chapter number 18. This article discusses about the utility of thyroid antibodies in urticaria. This article looks at the role of eosinophil. This article just tells us about the pathomechanism, the pathophysiology of urticaria, and this article is very good. The last one, Urticaria and Angioedema, Understanding Complex Pathomechanism. If you want to read about these topics that we have discussed in this video in detail, go and look at the individual articles. I will again copy paste these URLs in the description. Just get the full text and read. Very good articles. Go through it. Okay. So with that, I'll finish the video on pathomechanism of urticaria. Now, urticaria, understanding the pathomechanism is important because initially during residency, even I thought that the pathomechanism of urticaria is very easy. All you have to do is just give antihistamine, keep on increasing the dose, they will respond. But what happens when you give 4 times, 5 times the dose of antihistamine and the patient is not responding? What happens when you give cyclosporin and patient is not responding? What happens when you have to decide whether omalizumab should be given or not? Or what happens if you have a patient of angioedema or complaining of angioedema and you want to know whether it is hereditary type 1, type 2, whether we should have a store of C1 inhibitors, esterase inhibitors with us or not? It's a good idea to know about how these kind of disorders work. When you know what is going wrong, you can make it right. And that is what is important in patient care, that you should know what is what is not acting properly, what is the normal process, how it gets deviated from normalcy in disease, and then only we can make a good decision on how to treat. There's no point if your patient is not responding even slightly to 1 dose of antihistamine, they will not respond adequately with 4 doses of antihistamine. They will not respond with changing of antihistamine class. You have to shift to an autoimmune or a immunosuppressive regimen for treatment of those urticarias. Okay, so for all those people who have stuck with this video till now, I thank you for listening to me for more than an hour. uh, I know it's tough. These videos are tough to sit through. 1 hour is very long, but you don't have to sit and see this video without stopping. Take frequent pauses. If you don't understand, come back to the video, look at it again, view it at 1.5x the speed, develop an understanding. If you see this video, you will not feel any need to read about the pathomechanism of urticaria ever again. Trust me, every information you require at residency level is in this video. Just go through it, let it wash over you, let the mind absorb, and you will easily be able to answer any question related to pathophysiology of urticaria, or how to manage patients, especially difficult cases of urticaria which are not responding to antihistamine, or they keep on relapsing whenever you stop antihistamine. So that is how it is important. And so 1st October being the World Urticaria Day, again, we should remember it. It's a good Viva question, but you should also remember to create awareness about urticaria. And it is a very psychologically disturbing disease if it is not managed by antihistamine. And I think this would be the last video as of now on itching and pruritus. We have done first generation antihistamines, H1 receptor blockers. We have done second generation antihistamines, H1 receptor blockers. We have done agents which do not act via blocking histamine, and we have discussed in detail the pathomechanism of the pruritic pathway. And this video discusses the pathomechanism of urticaria and angioedema in sufficient detail for you to understand the process. I hope that this video was useful. Happy learning, and thank you for sticking to this end. You can email me your doubts, suggestions, anything you want to ask, anything you want to know, anything you want to tell and contribute. Do let me know. Comment all your doubts or suggestions or any queries below this video. I answer all my comments. I may be late, but I do answer them. And without further wasting your time, adios, bye bye, and enjoy this long weekend. And happy Gandhi Jayanti to all Indians and others. Tada, bye bye.